Recording now. There we go. Good. So we're going to start with wound care here. So what do you guys know about wound care thus far? Maggots. Okay, good. How many of you guys are interested in maybe doing some wound care? Nope, nope. Yes, okay. You take care of wounds. Mike, that's just brilliant. So some of you are interested, some of you aren't. It's okay. It wasn't something, I'll say that when I was in school, it was not something I was really interested in because I have this little bit of aversion to wounds. But ironically enough, I found out it was to my own wounds, not to necessarily other people's wounds. So what I found out was I went to my first clinical, or not my first clinical, my first job ever was at a major hospital in Pennsylvania. And I showed up on a Saturday and, you know, the person who was in charge, of the shift manager, was like, who knows how to do wound care? And I went, well, I mean, I did it in school. And they're like, congratulations, you're the weekend wound care therapist now. Oh, okay. So it was some interesting stuff. And, you know, it's kind of interesting. The neat thing about wound care that I really like about it is it's not as intensive as a PT treatment as some of the other stuff we do with transfers, with wheelchairs, stuff like that. And you're not as bound by time because the units for wound care are based on the size of the wound. So the bigger the wound, the more units you get. The smaller the wound, the less units you get. So it's a little bit different in the style, right? Ignore this date. I didn't take that off. I wanted to take that off. So let's look at skin, all right? So skin is the largest organ in the body. It weighs between 6 and 8 pounds, and it's about 1/3 of the body's blood volume. So when you think about that, 6 to 8 pounds of your body is your skin. And for some of you, that's a large percentage. For some of us, like me included, the 6 to 8 pounds is not that much of your body, right? But for some of you guys, that's a pretty hefty chunk of your body. And receiving 1/3 of the blood's volume tells you a lot about it. What are some of the jobs of the skin? Do you remember? Protection's the main one, good. What else? Yeah, thermoregulation's a good one, right? Thermoreg's big. So with protection, it does a couple different protection, right? It protects our organs. Obviously, we have the skin to keep everything inside of us. But it also protects us from viruses and other injuries like coronavirus and stuff like that, right? Because if something gets on our skin, we have a natural flora and fauna. We have natural bacteria that grows on our body that kind of helps us with making sure that we actually get some protection, right? So what would cause that protection to break down? What could cause the skin to break down? Lacerations, right? Trauma, any lack of moisture, good, right? Skin has to be moist. Heat could cause it, right? If we get a burn, right? Or even if we get an extreme cold, friction, the environment, pressure injuries, all of that comes right into play. You're exactly right. So all of that ties in with this. Anything that chemicals, oh, there's a good one, right? What happens if whatever you're messing with stuff, specifically like lye or any type of really bad cleaners, and that gets on your skin, that can definitely affect your skin overall. But our skin's really important because it's going to protect us overall and allow us to do things, right? So here's kind of a review of that anatomy, right? We have our epidermis, then we have our basement membrane, then we have our dermis, our subcutaneous fat, and then our deeper tissues. Between each of those layers, what do we have a little tiny layer of between each of those layers? To separate out the layers. Yeah, a little bit of fascia, right? And you guys kind of learned a little bit about that when we were doing that myofascial release in Dr. Ovreskin's massage class, right? Where, it was funny because some of you, I saw, we get in this habit when we're doing massage, we want to put pressure on to relieve that fascia, right? But in real time with myofascial release, we don't want to put a lot of pressure. It's just some gentle pressure where we're allowing that fascia to kind of slide, right? Because what could happen if that fascia doesn't slide and move around? So if we get maybe the fascia that's down here between, it adheres down, right? So maybe that fascia down here, where's my annotation? There we go, rotation. There we go. Down here under this fat layer kind of breaks down or gets stuck. Now that fat's going to adhere to the muscles underneath here, right? And so then everything's going to get kind of stuck. Movement's going to be limited, right? And that's going to cause all kinds of problems. So we don't, we need that fascial layer to be movable. So major functions of the epidermis, the outside, protective barrier to the outside environment, aesthetics. Skin, hair, and nails all originate in the epidermis, right? So that aesthetics portion, that appearance portion is really kind of important in certain societies and not as important as other societies, right? In the United States, would you say that appearance is important? Do you think that aesthetics of your skin, yeah, right? Maybe a little too important, maybe, right? That the appearance of your skin may sometimes preclude you from getting things in life. That's kind of the sad way. We all prejudge somebody, right? And that skin can really affect, the appearance of that skin also can affect, some of your outcomes in life as well, which is kind of terrifying. That's not the way. The skin's job is to protect us, right? It's not necessarily to classify us in certain classes. Take, for example, if we have somebody of African-American descent, we have somebody of Caucasian descent. If we look at the epidermis itself, is there a true difference in the epidermis? Yeah, not in the actual epidermis itself, right? There may be some pigmentation differences, but there's not a difference structurally to the epidermis. The epidermis is the epidermis is the epidermis, right? So, classifying people based upon their, skin color is kind of weird. So then we go deeper and we go down to that dermis, right? So the epidermis, meaning on the dermis or on top of the dermis. The epidermis has a lot of collagen and elastin in it, right? It gives us our tensile strength, right? It allows the skin to be elastic. And what did that physics term mean again? Elastic. I know, physics so long ago. Yeah, the ability to return to its original shape, right? The ability to stretch is what we think of with elastic, right? Because when we think elastic, we think rubber band, right? But the real point of elasticity is the ability to not only be stretched, but then to go back to its original shape. Does that elasticity ever get changed at all in the skin? Yeah, right? As we get older, the elasticity starts kind of becoming less and less pliable. That's when that elastin starts breaking down, right? Overall, as we get older, the ability for skin to return to its original shape becomes compromised, right? Now, there are things we can do to mitigate that, but overall, the skin is going to break down as we get older. We have our blood and lymph vessels down there, right? Lymph is important for transporting fluid to the body. It's also it's important for the, the humoral response, so the actual immune response to us, right? But both blood vessels and lymph vessels can become compromised. In the case of blood vessels, we can end up with clots. In the case of lymph vessels, we can end up with lymphedema and swelling. And then we have all those fun nerve endings, those Pacinian corpuscles and Meissner corpuscles and baroreceptors and, thermoreceptors and chemoreceptors and all that out there that help regulate everything. The main job of the dermis, obviously, is infection control because it's got the lymph and the blood in there. Thermoregulation's there as well. And sensation's the big part. Well, do we want to put all of our important nerve endings out in the epidermis? No, that'd be silly. Exactly, right? Because if it's in the epidermis, our epidermis shears off all day, right? If you look around your house and you have dust laying around your house, I hate to tell you this, some of that dust is dead skin cells, right? As you sit here, and even as I'm moving around, dead skin cells are shearing off me, right? When you sit in your home, you're breathing dead skin cells just to freak you out a little bit, right? And so those dead skin cells just kind of flake off of us and they die. They're supposed to. If every time those dead skin cells flaked off, they exposed raw nerves, that would be a problem. That'd be kind of painful, right? So we want to make sure that those nerve sensations, those nerve endings are a little bit deeper. Now we get down to the subcutaneous fat or the subcu tissue, right? Now we get down to the fat and everything like that. A lot of adipose tissues there. What are the two types of adipose? Brown and what? What's the other one? Brown is the better fat, white's the worse fat, right? Do we need both though? Somebody like, well, we got to cut down on all of our white fat. You can't cut all your white fat out. Yeah, you need both, right? It provides cushioning over bony prominences, right? Just, you know, if you didn't have a little bit of that adipose in your butt, just sitting here listening to this meeting would be literally a pain in the butt. So you need a little bit of that cushioning, a little bit of that sub-Q tissue to provide you with some overall cushioning and everything like that. And then when we get down, you know, and a lot of times, for those of you that have pets, right? Did you ever hear when your pet got sick that they were giving them sub-Q fluids? Right? So sub-Q means they're literally going down into that subcutaneous fat, and that's where the needle's setting to give them fluid, right? It's not going into a specific blood vessel. It's just going down there. So how does it get taken care of if you're just sticking it into the subcutaneous fat? What's going to happen there? Yeah, it's going to get absorbed, right? You're going to get that osmotic effect, and the tissue around it's going to kind of absorb it up. Now, if you have different types of lymph issues, that can be a problem, right? Because that sub-Q can then just kind of ball up all that fluid, and maybe it won't. So it may not be the best option there. Have any of you ever gotten sub-Q injections? Pretty confident some of you got some sub-Q injections, right? Once you got your, what were some of those? Yes, the TB, all those are kind of sub-Q. They're the cause and effect, right? TB is more going down into the actual dermis itself because we want it to get down to that immune response area. But specifically, if you have something like, you know, a blood sugar problem and you're controlled by insulin, a lot of times they want that insulin to get down to that sub-Q fat level so that it can actually provide some absorption. Okay. Sorry, something happened in my house and I didn't know how it happened. So tissue involvement. This is where we start talking about wounds. So what all could cause a wound to the body? We talked about friction, right? Friction can cause a wound. What else? What about a knife? Heat, maceration, good, right? Gunshot. Any of that can cause specific issue or wound to the body, right? So when we talk about things, we used to talk to them about superficial, partial, thick, or we used to say specifically burns. We call them first degree, second degree, and third degree burns, right? We now talk about them by the level of skin that's affected. Same thing with wounds. So superficial wound affects only the epidermis. What would be a good example of a real superficial wound that we probably all get on? Yeah, a paper cut, right? Paper cuts are annoying. Right? So they're especially when you finally put on some hand sanitizer, if you actually have any of that, and you find the paper cuts. Or you decide to cut an orange or a lemon after you've got a paper cut, and you're like, oh yeah, there's that paper cut. It feels great. Right? So you've got those superficial wounds. Now we have a partial thickness. Now when we get partial thickness, we've not only got that epidermis, but now we're starting to get down into that dermis level, right? So it's going a little bit deeper. And then we talk about full thickness wounds. And full thickness wounds go through the epidermis, through the dermis, and then down into that sub-Q fascia and muscle, right? So that's what we're getting some bad ones. Out of all of those, obviously, yeah, stepping on a nail is an excellent example of a full thickness wound, right? That would be not very fun, right? It's not there. So then that begs to ask, how do people lay on beds of nails without getting wounds? You know, if you step on one nail, it's going to go through it, right? Very carefully. Yeah, it's pressure distribution. That just literally shows you the tensile strength, right? Or that elasticity of the skin. If people can lay on a whole bed of nails and not get any wounds, really focus. Yeah, that's important too, right? But what's the part of the focus? Well, the part of the focus is making sure that all the body weight is distributed evenly and not one specific part has heavy, a lot of weight pressure, a lot of pressure on it. So that allows that body to be distributed evenly out across that whole thing. Oh God, the phases of wound healing. Remember all this? We have inflammation, proliferation, maturation, and remodeling, right? So that allows, that's kind of the standard phases we go through. So this is your kind of normal cycle of wounds, right? So a lot of times that inflammation phase is about 4 to 6 days. Now, some will say 4 to 8, some will say a week, some will say 2 weeks, but understand it's somewhere in that 4 to 6 day cycle, right? As we get closer to the end of that 4 to 6 weeks or 4 to 6 day cycle, right, we're starting already to go into proliferation, where everything's are starting to get repaired and laid down. Now, that proliferation cycle can get affected by, your health level, your overall nutrient intake, your water intake, everything like that. So just because you start in that proliferation phase doesn't mean that everyone's proliferation phase is going to take the same amount of time. Also, your level of injury, right? If you have that really partial thickness wound, right, it's going to heal a little bit slower than a superficial thickness just because of the layers involved. And then with the remodeling phase, look at this, remodeling, it's underlined there already. It can take up to 2 years for remodeling to kick in, right? And that's kind of scary because and this may be something you have to deal with your patients, especially if you've got somebody that's older and has consistent wounds. These wounds may never fully heal, right? And when those wounds don't fully heal, they're more susceptible to re-injury. So you've got to kind of make sure that when you're working with those older patients, that they're doing everything that they're being told to do in order to heal. If they don't get all that stuff that they're told to do, they may not heal properly. So they've got to do everything they're told to do. So in the inflammation phase, within 24 hours, 4 to 6 days is the normal thing. The main thing here is, we often talk about we need to reduce inflammation, right? Inflammation is a normal response. So that was good. Yeah. Inflammation is a totally normal response. That means we want some inflammation. Is that correct? Yeah, right. So let's take a look at we're going to use the coronavirus here since we're all dealing with this scary outbreak. One of the big recommendations they're making right now with coronavirus is if you can tolerate it, you want to try to maintain your fever as long as it's within a reasonable level, right? Well, why are they saying to maintain your fever? So maybe not to take as much Tylenol to lower that fever. What happens during that pyrexic period? Yeah, the body is fighting it, right? It's using a lot of energy to fight the virus off. Sometimes, especially parents I'm not gonna say guilty of this, but parents, obviously their kid gets a fever. What's the first thing they're thinking? Yeah, cool rag, reduce cold temperature, right? A lot of parents, they see that it's time for the children's Advil or the children's Tylenol, right? But that can actually delay the overall effect of healing, right? Back when I grew up, if we started getting sick, it was funny because, and it's an old school remedy, is you go back to bed and you bury yourself in blankets, right? And you're like, that doesn't sound very, good, Jackie, right? Yeah, Vicks, right? Why would we want to increase the overall body temperature? What happens if I just go lay under a ton of blankets? Yeah, right. So first of all, it's going to increase your core temperature, so your body doesn't have to do it as much itself, right? So there is some science to that. Just saying, well, go lay under a bunch of blankets, And also where I'm from, the other thing was drinking fluids or drinking alcohol. Depends. That's where I was going to go next, right? Yeah. So that's a double-edged sword. Right? Yeah, because whereas we're going to talk about where I grew up, what they used to do to you even as a kid, and this explains a lot about me. It was called the Jack and Blankets treatment. You get a shot of Jack Daniels as a kid and get shoved under 50 blankets. That was grandma's old recipe. Hot toddy, exactly, stuff like that. But the idea of that is, the theory of it is, when you have alcohol in your body temperature actually does naturally increase and doesn't require as much of your body energy to increase the temperature. And I'm going to get back to Russell's question in a second. So there is some theory to that. The downside to it is alcohol also then, right, is that anticoagulant, and it also forces the body to urinate a lot more, which is going to force more of your fluid out of your body. So it's also a dehydrator. So balance it out there, right? Obviously, the better is to go just lay under some blankets and kind of sweat it out, or that's what they call it, right? Let the heat get out. But I'm not going to say that's the wrong way to do it. I'm not going to say it's the right way. That was the way I grew up with it, right? Russell, with the fact that we questioned about ibuprofen, there are some studies that show with specific people, the ibuprofen can cause a negative effect with coronavirus. The study that I read, it was mainly immunocompromised people. And that kind of makes sense because you're going to get the Advil, it's going to affect the overall immune system, blah, blah, blah. But if you have a fever already and your fever is above 102, take something, right? Bring it down to a reasonable level. But 102 above, we definitely want to be careful because that can blind a person. It can cause neurological problems, stuff like that. With wound healing, we had the same thing. Inflammation is normal. I keep rubbing my knuckle because I was hitting the heavy bag and I've got a nice little scab and cut on my knuckle. The first day after that scab on my knuckle, the whole area is kind of swollen. That's normal, right? That's a normal response. The goal of inflammation is controlling bleeding, right? It also combats infection. So if I swell up that area and I can bleed, what's the bleeding going to do to that wound? What's going to push any type of infection to the outside of the wound, right? That's the idea and the goal behind this inflammation phase. We want to control the bleeding, we want to combat infection, and we have this vascular response. Initially, let's say I've got a cut, right? So I've got a cut through my arm, and that cut in my arm starts bleeding. It's going to bleed for a while. Eventually, the body's going to vasoconstrict. It's going to try to stop the bleeding, right? Once the bleeding is controlled by getting a scab or some sort of a wound covering, the next thing it's going to do is vasodilate and bring more blood to the area. More blood to the area's job is to help improve that healing response, right? It's going to be a whole huge list of cells going there, right? We're going to have some red blood cells bringing oxygen and nutrients, right? We're going to have our lymphocytes or monocytes, neutrophils, macrophages, mast cells. All of that are going to converge on that area. So that means if we did a blood sample near a wound, right? So if we took we had a cut and we did a draw sample right near that wound, we would normally see a higher than normal blood count at that area. And that's normal. That's the way it should be, right? I haven't seen, it'd be interesting to see somebody do a study between the blood count at the actual wound and maybe on the opposite side of the body where there is no wound to see how those compare. I'm guessing probably the side of the wound is going to have higher, white cell counts and a little bit higher red cell count as it's healing. Right? That's normal. Now, the downside to that is if you have this immune response going, sometimes that immune response can go out of control. Thanks, Ian. So that immune response can cause all kinds of problems. So we got to be careful. There's got to be that delicate balance of normal immune control and then out of control immune system. So who do you think, what type of patient would have a problem? They get a cut and they get into this inflammation phase, and maybe the inflammation phase itself gets trapped there. What type of patient might get trapped in the inflammation phase? Diabetes. Exactly. That's a great example, right? What other conditions maybe? What about somebody with lupus? Blood clotting disorder? Yep, there's another excellent one. What about somebody with lupus? Could they get stuck? Yeah, systemic infection, systemic anything can get them stuck there, right? So that's important to understand that, we got somebody with an autoimmune condition, which even diabetes can be classified as a little bit of an autoimmune condition, especially diabetes 1. We've got to be careful with them because they can end up stuck in this inflammation phase, right? What can we do as therapists to help control that inflammation? We already talked about Tylenol, right? We got that. Cool rag. What other stuff can we do? Modalities, right? We can mobilize them too. Exactly. Right? So any type of movement, we have specific modalities like cold. Some laser has shown some great response to calming down inflammation, right? So all kinds of modalities that we have for that. So that's the important thing. But mobilize is big. That is our whole job. Our whole job is to mobilize the patient, get them out of bed and get them moving. And even with these wounds, we still have to make sure that they are moving, because if they don't move, that wound can get significantly worse. So typical classifications of inflammation, right? We have heat, edema, localized redness, pain, and decreased function. When you're in inflammation, it's helping your area, right? Heat is important, the edema is important, localized redness, which is erythema, right? And I said the term for that fever, or the increased area of heat, what's that called? What's the medical term for that? No problem, Jared. Pyrexic, right? Yes, meaning being with fever. I always remember that from, because I think I have a Pyrex, what do you call it? Measuring cup. And I always think that because I always heat my hot water up in that. So that's how I kind of always remembered it. I think they're even spelled the same if I remember correctly. But yeah, so pyrexic meaning heat in that localized area. Localized redness, that erythema. What's the term for pain? Ow. Well, noxious could be a term, right? That's a specific type of pain. What is Tylenol considered? What's the term for Tylenol? What's the technical term for Tylenol? Analgesic, right? That means lack of pain. That means analgesic could be pain, right? We talked about the hyperalgesia, right? Hypoalgesia, meaning low pain. All that, that's the goal, is where you have that pain. And decreased function is going to make sense. If we have heat, we have swelling, we have redness, we have pain, we stop moving. That's kind of the way we think. And obviously, it may not be the best option for us. So the next phase we move into is proliferation, right? This is, from about day 4 and on. The first thing that happens is angiogenesis. What is angiogenesis? Circle of Willis. No? Well, Circle of Willis is played into it, right? It's formation of new blood cells and formation of new blood vessels, right? It's new tissue growth in that area, right? So we're starting to get some things growing in, specifically new blood vessels coming in to form that nutrient layer for all the stuff that's going to go, right? What's the term for Circle of Willis again? It's not angiogenesis. It's anastomosis. Close enough. You spelled it close enough. Good job. Anastomosis. That's great. So we have that angiogenesis occur, right? And we have the granulation tissue coming in, right? So we're going to start coming down and we're going to lay those layers down to kind of build up that tissue. The wound itself is going to slowly contract, right? It's going to heal itself and slowly close off. Epithelial integrity is going to start being restored, meaning you're going to start seeing that skin kind of growing back and getting a normal layer back. All that's going to occur with that proliferation phase. So here's kind of what it looks like for a wound, right? I don't know why they cut this perfectly square wound into somebody, but it's kind of creepy, right? I think that actually was just an injury on a person, right? So we have this, square wound here. As everything goes along, right? So we get into that proliferation phase, the wound slowly gets smaller and it's going to close from the outside in. What type of healing is that called? Primary, or what's the other term for it? Healing by what type of intention? Good. Healing by intention. First intention. Good. Right? Great. That's exactly right. So healing by first intention. That's where that wound kind of just draws in, right? And that's why if you get a little cut on your arm or something like that, right? As that wound closes, what happens to the scab that's there? Do you ever notice that scab kind of pops up and raises up off the skin? Yeah, right? And then you get some of those weird people that are like, ooh, scab. Tick, 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 right? Don't necessarily always want to do that, but there are some weird people that do that. I'm not going to judge if you're one of those weird people. But that's what's going to happen. It's going to slowly close in. It's going to push that scab up and out, because that's dead tissue, and say, okay, we don't need this anymore. We have fresh, healthy tissue. My scabs all the time. Bison, how does that just not surprise me? I'm just saying. TMI. We're all friends here, right? So here's that kind of wound contracture, right? So the initial injury, everything's kind of split apart, right? And so here we're all opened up. Everything's going to start coming in. Here's some of those granulation tissue starting to get laid down. And then the wound itself is going to start healing up and out, and then these edges are going to close in on each other, right? So that allows the wound to actually heal. So that's important for wound healing. We want it to actually heal itself. Now, in wound care, when we talk about a wound bed, we're not talking about a Sealy or a Posturepedic or, you know, a purple mattress, right? What is the wound bed? Your bed, yeah. What does wound bed mean? What do you think? Give me an idea. Bottom layer, right? Yeah, so where we get down, maybe the dermis, may not be, it's exposed underlying tissue. That's an excellent kind of a generalized term for it. That's actually an excellent generalized term. It's the exposed underlying tissue, whether that's just epidermis, whether that's dermis, whether that's dermis and underlayers. That wound bed is what we can see that we shouldn't see, right? So let's say that this patient here, annotate, that this wound bed is on their epicondyle, right? At this point, looking at this wound here, right? This wound here that we're looking at, the epidermis is affected. So if that's an epidermal wound, what type of a wound is that? It doesn't look like the dermal wound, right? So it doesn't look like the dermis is affected. It may be, there may be a little bit damage there, I can't tell. But that would probably be a classification of a superficial wound, just the epidermal layer is affected. Now, if we started getting down in here and we started cutting out and started getting down into that dermal layer, now we're going to start getting into what type of a wound? Partial thickness, good. And then let's say, again, let's say we're down here on that elbow and all of a sudden you can see the tendon for the triceps. So now what are we into? Full thickness, good, right? So that's kind of the way they work. Magically, that sounds a lot like what other type of scale have we learned that kind of talks about those type of wounds? Burns, good. And one other, pressure injuries, good, right? So that kind of looks a lot like those. So then we move into this remodeling phase, right? Remodeling phase is where things start getting better. If you remodel your house, you may be doing it to make the house look nicer. Well, the same idea comes here, right? The remodeling phase of your skin is to make everything look nicer and get it back to normal function, right? And just like your house, when you're doing a remodel, sometimes it takes a short amount of time, sometimes it takes a long amount of time. It just depends upon what effort you put into it, right? And then everything that goes on top of it. So tissue is starting to get strengthened and reorganized to fit the surrounding tissue. And then you get this scar formation, right? I've got a beautiful scar right here on my neck from having my neck surgery. But the important thing about scar tissue is it's only about 80% as strong and as elastic as the original tissue, right? So I'm going to use myself as a great example because when they did my posterior fusion, they did the scar tissue, they did the cut, I healed up, but they had to reopen it because one of the screws became loose, right? So I lost 20% of my initial tensile strength initially, right? So now my skin was, only 80% as effective. Well, then they did it again, and I lost another 20% from that. So that's why if you guys ever take a look at that scar that I have on my neck, it looks very gossamer and thin. The actual elasticity of that skin is pretty greatly compromised, right? So with that wound I have in my back of my neck, is that going to be more likely as I get older to break open? Yeah, right? It's kind of terrifying when I think about it because it's on my neck. But yeah, as I get older, right? And especially if I have to have other surgeries, if I have more surgeries, well, then I'm going to have another surgery they're going to have to open. It's going to become 80% less, right? So that's kind of scary when you think about it. I mean, right now I'm probably somewhere in the range of about a 74%, 72% effectiveness of the skin in that area, if I did the math right. 64%, I think. Yeah, something like that. Anyway, math is hard. So as that gets down, it kind of breaks down that skin tissue and it's not going to make it heal as well. And some of you may have had that before. So that's why I'm trying to say it. Exactly. Math is hard. I told you guys that at the beginning. I said math is hard, physics is harder. Now let's say, I mean, has anyone had an area that they've cut and then it's reopened on them? Right? And then it took longer for the second time to heal. Yeah, right? So that's what we got to be careful of. You got to kind of protect those areas that have been previously injured. Same thing happens to kind of bones and other tissue as well, right? You tear a muscle, you're more likely to tear that muscle in the future because it's not as elastic. Hurts more too, typically, right? Yeah. It may even megahertz. So, I know, you guys missed my jokes. I know you did. So, immature scars are modifiable. Mature scars are not. What is that? Why is that underlined and important? Why do you think that's kind of important to us? Bob is my uncle. Good. Yeah, sorry, scar mobilization. Exactly, Ashley. Fantastic. Great. So it's important that we, as soon as we can, with any type of a wound that a patient has, mobilize that scar, right? As I have a hole in my lip. So let's take a patient that's got a total knee replacement, right? The sooner we get treated, the better, right? So let's say we have a patient with total knee replacement. We're gonna have that scar. What's that scar often look like on a total knee replacement? So we usually have a term for it. Gross, okay, that's not, hopefully not. Well, it could be keloid, right? But a lot of times you'll hear in the hospital, we'll call it a zipper scar. And that's because a lot of times with total knee replacement, what are they gonna close it with? Not a zipper. Staples, good, right? They use the easy button and they close it with staples. No, okay, fine. All right, so the staples. So when you look at that scar afterwards, it often looks like it's a zipper, right? So we want to mobilize that as soon as we possibly can. You know, most of the docs won't allow you to mobilize. I know, I'm trying. Won't allow you to mobilize the scar while those staples are in. And that kind of makes sense because if the staples are in, mobilizing the scar may not be the best idea, right? But then once we get those staples out, we should start mobilizing that scar. And it's important that we also not only mobilize that scar, but we teach the patient how to mobilize the scar, right? They should be mobilizing it as much as they possibly can, as much as they can tolerate. The more you mobilize the scar, the less chance you have of going into keloid scarring or any type of negative scarring, hypertrophic scarring, all that stuff. The less chance you have of it binding down to the tissue underneath. I'm going to use my neck scar here as an example. You can see kind of, I don't know if I can get in close enough, but you can see how it kind of is all healed over and doesn't look normal, right? I've got a little bit of keloid scarring there. Worse than that, and I did mobilize my scar. This was just a bad cut. Worse than that, that scar has adhered down to, what's that muscle that lays right underneath the superficial layer of your neck? Well, hyoid's there too, but really, not SCM, the one that's really superficial. Not plasma, but close. Platysma, right? There we go, good. The plasma muscle, I love it. Close though, good try. So platysma muscle, right? It's often called the muscle of shaving, right? Because you can tighten it up to allow you to shave a little bit. I know what you meant, Jeanette. I'm still picking on you. It was worth it. So that my scar is bound down to my platysma, right? So when I'm shaving, it's a lot harder to shave that area, and I actually have to separate the scar out because the platysma won't stretch it to allow it to move because it's bound down to it, right? So the more we can mobilize these scars. Now, my scars here, what are the chances of me mobilizing here? I'm going to mobilize it real quick. Is that really going to help it much at this point? Now, for example, my surgery was 2013. Yeah, no, right? It's there. It's pretty much stuck down. Now, there are some studies that have shown you might get a little bit of improvement, but not a lot of improvement. That's just kind of what it shows. Yeah, it's consistent. That's the thing. That's the key thing, right? And that's the problem with patients. If they consistently take care of their scar, they can improve their function of their scar. Now, there will come a point where that scar just doesn't do much else. You know, you might get a 5% reduction in adhesion, stuff like that, but it's not going to improve like it did at the early phases, right? So we want to get them as soon as that scar is laying down, as soon as they enter that remodeling phase. Your mask off, seat. As soon as they enter that remodeling phase, they should be starting to mobilize that scar. you know, I want them to mobilize it as soon as possible. I teach patients as soon as those staples come out how to mobilize. So what type of massages can we do to help mobilize scars? Cross friction, right? Good. That would be going which way on the scar? Obviously, across the scar. What other can we do? You learned some of them. ISTM, good, right? Instrument assisted. That actually works out really well a lot of times, is doing that. Cupping can work, definitely, as long as that scar is mature enough for cupping. We wouldn't want to take, you know, just a fresh scar and start cupping it, because then it can pull apart, right? But we want to kind of, that mature scar kind of, not into the full mature, but where it's actually kind of closed up and looks like it has some tensile strength. What's a manual therapy technique? So it's not necessarily a massage, but it's a manual therapy technique. I wouldn't exactly call it a massage, but it definitely does some of the similar effects to massage, right? It's going to kind of lengthen out that tissue. Scar taping as well, good. So any of that kind of stuff can really help out those scars. Yeah, actually, that would probably, I'd be willing to bet if we look at it, cupping probably does fall under ISTM. I have to look into that. That's actually a really good question. I would consider it manual therapy for sure. I'm not good at cupping. Hopefully when you guys get back, maybe Dr. Rest can still do her IASTM class and her cupping class, which is usually a really big hit with the students. So hopefully we can still get that when you guys come back and get a little bit of fun going on with that, and we can tear at some of you guys' muscles with the tools, right? You missed her. She'll be coming into some of the 204 classes from what I understand. She's gonna help out Dr. O'Neill and Dr. Selka with that class as well, and myself. So that's the main thing. Where we got off track there for that is that we wanna make sure we're moving the scars. We actually have a set of cups, believe it or not. I don't know if you guys know that or not, but we have a full set of IASTM tools, and we have a full set of cupping tools that are in the modalities cabinet. And she is really into the whole cupping and IASTM thing. I'm not so much into it. I still prefer manual hands-on type stuff. That's why I'm gonna get probably more arthritis than she's ever gonna get. Make sure you sanitize. They are sanitized. Yes, especially now. So we talked about primary intentions, secondary intentions where everything kind of heals weirdly. And then they have this what's called delayed primary intention. A lot of times this delayed primary intention that we're talking about down here, a lot of this are people that are older. So what do you think delayed primary or tertiary intention healing means? What do you think? I know I'm making you think. Well, inside out's kind of the way that the secondary intention works, right? But the main thing with delayed is it still heals like normal, but instead of following that normal path of inflammation, proliferation, remodeling, and maturation phase, it kind of moves at a much slower phase, right? Same idea here that we have that kind of that, remember we hear about with coronavirus flattening the curve? Well, with delayed primary intention, the curves of healing are flattened. So it takes a lot longer to get where we need to go. And that's why a lot of older people are more susceptible to repetitive wounds, because that's going to cause problems if it delays the healing itself. So here's the primary intention, simplest and fastest way. Reepithelialization only, no granulation tissue, superficial wounds, deep wounds with approximated edges. There's a low risk of infection. So if you heal by primary intention, the younger you are, the faster you heal, exactly. If you heal by primary intention, you have a really low risk of tissue infection. You also have a minimal risk of tissue loss, and also usually minimal scarring. So we can do things to help wounds heal by primary intention, right? Let's say I get a long cut on my arm. What could a doctor do to actually get that wound to close itself? Stitches, right? Or as I say, I really don't want him to do it, so he'll give me the stitches and tell me, suit yourself. I've been waiting. I was waiting for that, right? So stitching, right? We're approximating those edges. The easier those wound edges are able to approximate, the better overall it is, right? Also, obviously, the smaller that wound bed is, right? So why is this not working? Zoom is deciding to be a little bit of a pain today, right? So the smaller that wound's actual cut is, the better the chance it has to keep stuff from sneaking in. So those viruses don't try to sneak in and get down here and infect you, right? So what about a huge wound? Let's say that we're working with a patient and they're older and we slide them across the bed and we get a shear tear. So literally, you know, 6 inches of their buttocks kind of tear off. Is that going to be more susceptible to an infection? Yeah, right. The bigger that wound, the more susceptible you are to an infection. What might we have to do to something that's that large in order to keep it from, it sounds like a sentinel event. It would be a sentinel event. What might we have to do to keep that from getting infected? We definitely have to dress it. That'd be 100%, right? But what might a surgeon have to do? Graft it. Yeah, they may have to take skin from somewhere else to cover that because maybe the wound is too large that it won't close on its own. So they've got to lay something over it to allow those wound edges to kind of approximate again. So it's important that they understand that, right? So secondary intention, this may require wound repair, requires granulation tissue. These have a higher risk of infection and greater degree of tissue loss, right? So this is where the granulate, instead of the normal healthy tissue filling in that wound, granulation tissue fills in, right? And granulation tissue is less like the original tissue around it, right? So if granulation tissue fills in a wound, and specifically fills in the area where you should have epithelial cells, that granulation tissue isn't actual epithelial cells, right? It's collagen and all that stuff, fibrillin and elastin, but it's not as tensile strength as that original area, right? The more that these wounds heal like that, there's a higher risk of infection. There's a greater degree of tissue loss, longer healing times, and you'll end up with visible scars, right? We're gonna talk about granulation tissue in a little bit, Gisette. So we're gonna, give me a second, because we're actually gonna talk about that in a few minutes. So if we fill in that, so what I would think about is, let's say that you have a hole in your yard. So you got a gopher and the gopher has dug a hole in your yard. If you heal it by primary intention, you're gonna put normal dirt down in there, you're gonna lay some grass seed over it, the grass is gonna grow back and it's gonna look like there was nothing ever there, right? Secondary intention would be, instead of filling it up with dirt and grass seed, you go and you get some concrete and you pour that concrete in there and you fill it up. That concrete would then be the granulation tissue, right? That area of your lawn is never gonna be as elastic as it was, right? But at least it's closed over. Hopefully you didn't close the groundhog in his hole. That would be really neat. But that's kind of the difference between your typical primary intention and your secondary intention. And this is kind of the whole process of doing it, right? So granulation tissue is that collection of collagen. We're going to talk about that in a few minutes here, where it doesn't wound, right? Here's that delayed primary intention, right? It's a combination of primary and secondary intention. It's often dealt with contaminated wounds to decrease risk of infection. It often goes along with patients that have maybe some sort of an open surgical wound after they've had the surgery, but it's delayed in its overall healing. And at that point, they are going to have a greater scar, but hopefully that scar is not as bad as maybe that secondary intention scar is going to be. So acute versus chronic wounds. Acute wound is one that looks great, right? It's acute wound. No, it's joking. Acute wound is where the wound is brand new, fresh, everything like that, right? So maybe I reach over now to grab my soda, and for whatever reason, I left my knife open on my desk. And instead of grabbing my soda, I grabbed the blade of my knife. That would be an acute wound, obviously. Surgical wounds could be acute wounds. Traumatic wounds would be acute wounds. Usually, if you're a healthy person, those acute wounds will heal fairly quickly, and you'll have normal function and return of skin, right? Chronic wounds. This is where we start talking about those patients with other complicating conditions, right? Such as diabetes, such as, autoimmune conditions, such as rheumatoid conditions, all of that fun stuff. It doesn't progress through the normal healing process. They may heal by secondary intention. And when that happens, there's usually some sort of either full thickness or partial thickness skin loss, and it's usually associated with the pathology. Why would diabetes cause somebody to not heal properly? Why do you think? Yeah, blood flow could be compromised. Great. Right. What's also secondary health factors, right? Lack of nutrients is a big one, right? So a lot of patients that have diabetes typically aren't eating the healthiest type diet. And then we can also end up with nerve damage, right? Yeah, let's say I've got a cut here, excuse me, and I don't know it because I've got diabetes and I've got peripheral neuropathy. The likelihood of me going through and reopening and re-injuring that wound is pretty high. And I'm gonna end up with a chronic wound, right? We gotta be careful with those patients that have these problems so that they don't develop into those chronic wound phases. All right, so other factors affecting wound healing. Wound dimensions. If you have a circular or a puncture wound that's circular, they heal slowest, then rectangular wounds, and then linear wounds heal fastest, right? So that's why when you get that paper cut, it heals pretty quick. It's a nice linear wound. It's a line wound. If you have a square cut, like we showed in that previous picture, it heals a little bit slower. And for some reason, circular wounds heal the slowest. And I haven't seen a study as to why that happens. I actually probably should look that up because it's actually interesting to me today. But circular wounds do tend to heal the slowest. Temperature is important. Maintaining normal body temperature is essential, right? We're going to talk about that with wounds is we want a warm, and then going down here, we want a moist environment, right? So the wound has to be nice and hydrated and keep with fluids in that area, right? Gross. Warm and moist. When you have a chronic wound, they're typically hypothermic, meaning they don't have as much temperature, and that means we need to maybe add some temperature to it. We may do a little bit of heat treatment with the chronic wound in order to try to get it to close a little bit better, right? But we know with an acute wound, we don't want to do a hot pack. Why? What's the hot pack going to do to the area that we may not want? Yeah, we're going to vasodilation, right? And I'll feed the inflammation. That's right. That's why we typically don't always do hot packs. But maybe with a chronic wound in wound care, we may actually add some heat to it to traditionally increase that blood flow and get that inflammation kicking in, right? So it's a very balanced, in fact, actually, yeah, you theoretically would heal faster in a more humid area, in a warm, moist area, as long as you also can protect the wound, right? So if you protect the wound in a warm, moist area, you'll heal faster, right? In this area here, and some of you guys have experienced this, right? When you get dry skin because of the lack of hydration in the air around us, does it sometimes take a little bit longer to get it hydrated? Right? You may have to add extra lotion, right? Especially during summer, right? During summer, you may find yourself getting ashy elbows or something to that effect, and you have to use lotion more frequently. And the main idea there is if you keep it moisturized, you're less likely to develop a wound, right? Right now in healthcare, I'm hearing from a bunch of friends that they're really complaining about their hands because what are they doing more frequently right now specifically? And we always wash our hands, right? But we're doing it more frequently and we're using a little bit more aggressive soap in the hospitals right now, right? Because we really want to kill that bacteria so we're not carrying bacteria room to room to room. We're also using hand sanitizer a lot, right? And for those of you that will work or do work in acute care or maybe will work in acute care, like Alex, I know that he does work some in acute care, right? The more and more you use that hand sanitizer, the drier and drier your hands get. Right now, they may add an emollient, so some sort of a lotion to that, but it doesn't help that much, honestly. Your hands just dry out from hand sanitizer. It says his hands are immune to it. Just wait, just wait. But yeah, so the more and more, especially if you're doing wound care, good Lord, when I was doing wound care for Kindred full time, my hands just, from washing them and from wearing the gloves and from everything else, because back then we had to wear the powdered gloves and we had to use the you know, the baby powder that probably caused me cancer. My hands just dried out chronically, and it really stank. I constantly was having cuts between my knuckles and everything like that. So that just shows that hydration is important. So yeah, theoretically, you would heal a little bit better in a warm environment. Other things that affect wound healing: necrotic tissue. We know that if we start getting dead tissue in an area, the problem with that is dead tissue likes to kill other tissue, right? So if you end up with necrotic tissue, it likes to spread. So in physical therapy and us dealing with wound care, what do you think we want to do to that necrotic tissue? What do you think we're going to try to do? Yeah, we're going to remove it, cut it out, right? Exactly, cut it out there, Russell. I mean, oh no. So necrotic tissue, we want to get rid of it, right? What's the term for removing tissue from the area that we use? Excise could be, yeah. Excise is removing a large section, right? Where is text, right? Debridement, right? A lot of times we're going to do debridement in order to help so that that area gets a little bit healing, right? Okay. So we're going to do that a lot of times with these patients. Now, here's the big thing. What do you think our limits on debridement are as PTAs? Because we do have some limits. Yeah, no sharps, ask a PT is a great answer, right? Yeah, so, and different states have different rulings for what sharps debridement is. This is, again, another area. The APTA's official stance on debridement of wounds is that PTAs are not allowed to do any wound in which a sharp object is removing tissue from the human body. But they leave it up to the local states to determine what is legal and what's not legal. I always thought it was funny. In Pennsylvania, I couldn't do sharps debridement with metal, we call them with metal scalpels and tweezers, but I could do debridement with plastic tools. That made no sense to me because doing the same thing, right? Yeah, that sounds normal, right? Now, the good part is if you were doing debridement, you were supposed to be trained in it as well. Obviously, they trained me. So when you're doing sharps debridement, we're taking off. So we have mechanical debridement, right? We also have enzymatic debridement we're going to talk about. All of that kind of comes into play here. So let's say I've got an open wound and I get an infection in it. Can that delay my healing? Yeah, right? Other things, circulation. If we have an impaired blood flow to that area, that's going to cause problems, right? Oxygenation is also important, which is why sometimes when we have severely, open wounds, we may put them in chambers that improve their oxygenation, right? Where we may, or put them on supplemental oxygen. I've seen it before where a patient comes in and they don't need supplemental oxygen, but they get a wound and all of a sudden we're putting them on 2 liters of oxygen. And they're like, well, I don't need oxygen to breathe. What they don't understand is we're not putting that oxygen on them so they can breathe better. We're putting that on them to increase the overall oxygen volume in their lungs, so that hopefully that increases the overall oxygen volume in the area of the wound, so it helps them heal a little bit faster. Sensation, their lack of sensation, right? It can cause failure to recognize the area. Also, if they have a lack of mentation, where they don't even understand what a wound is, right? So maybe they're a little bit demented, that can cause things that will affect it. And then mechanical stress, right? Any type of shearing force, pressure, any type of shear, friction type force, anything like that can cause a wound not heal as much. Do you think we want a patient always laying on their wounds? So let's say I've got a cut on my butt. I don't want to always spend a lot of time on it, right? I need to relieve that pressure so that it can heal. And that may be problematic for people because maybe the only way they sleep is on their back. So we have to get them sleeping in other ways so that area has not got as much mechanical stress. Other things that can affect it. Age. You guys are going to heal faster than me. It's just the way it is, right? Nutrition and hydration. The more you eat healthy and the more hydrated you stay, the better your wounds heal, right? And again, I'm going to go back to this with hydration, because I'm as guilty of this as the next person. Hydration means water. Hydration doesn't mean Coke Zero, right? So consuming water, getting fruits and vegetables that have a high content of water is another way you can do it. If you're not a person that likes to drink water, eating watermelons, eating fruit that is high in fluid content can really improve your nutrition. Keystone Light, that's where you get to that borderline where you're like, well, is this water or is this alcohol? It's pretty close. Natty Light would probably go along that same idea, right? That's where you kind of, oh, is it alcohol or is it water? I'm not sure. Even Dr. Selkow would probably question if that's water or if that's beer. Medications, right? What kind of stuff, medication-wise, could affect your healing? Yeah, immunosuppressants, anticoagulants, right? Anything like that. What about clot busters, such as TPA? Could that affect it? Let's say I've got a wound out here and I've just got a clot forming and suddenly they give me an injection of TPA. What do you think is going to happen to that wound? Yeah, it's going to start bleeding, right? This is why when patients have strokes where they've got an ischemic stroke and they're given TPA, a lot of times we're not allowed to move them for 2 or 3 days, which already starts that debilitation phase, which is bad. But the main idea they're worried about is if I give them TPA and then move them, I run a risk of opening a wound somewhere, right? But also what the doctors have to balance is, well, maybe just letting them sit there like that might actually cause wounds, it might cause problems. Behavioral risk-taking. Gee, who do you think is more likely to do behavioral risk-taking? What demographic, Justin, right? Men, specifically what age range do you think? Yeah, 20s, good. Yeah, so they usually say 18 to 35, but I take it all the way down to like 13 to 25, somewhere in the range, 13 to 30. Yes, because that frontal lobe, exactly. And then somebody, what if you have a stroke and you have part of your frontal lobe eaten away at? Well, then yeah, you're gonna have behavioral risk-taking problems. Inappropriate wound management. So what do you think could affect their overall inappropriate wound management? So obviously, if they're not trained how to take care of it, right? So maybe they get a wound and, you know, the big thing used to be when at least when I grew up, was leave the wound open, let it air out. If you let the wound air out, yes, rubbing dirt in it. That was actually, believe it or not, there's some science to that, but because dirt's going to cover the wound up and everything like that. But yeah, letting it air, right? Clean dirt, yeah. So we say, oh, let it air. We want it to dry out. And then we wonder why now so many of my generation have scars, right? Because we now know moist wound enclosed is better. But what about socioeconomic status? How could that affect their inappropriate wound management? Not changing dressing frequently or enough, exactly, right? Lack of supplies, right? Let's just say that I am in the lower SES phase, lower SES of the economy. Are wound care supplies cheap? No, right? Especially right now because, I don't know if you know, but I've gone to pharmacies and that some of those wound care prices are now a lot higher than they used to be because what's increased? Demand, right? And we know that we are a traditional capitalist society. So when demand increases, price goes up, right? That's why the McDonald's no longer has the dollar menu, right? They drove demand for their dollar menu, and now they have the $2, $3, and $4, $5 menu, right? It used to be just the dollar menu. I had to wrestle a bear for my N95 mask. That's great. I actually sewed a couple of my own masks. So not N95, but at least gets me through when I'm out running. But yeah, medical cost supplies are not cheap, right? And maybe they don't have access to it. That's why with case management, if you send somebody home with a wound, they need to understand if that patient has access to appropriate care and stuff like that to take care of that wound. If they don't, they're not going to take care of it. They're going to be back in. Something like a wound vac. Those can be really expensive if you don't have insurance. And so we may have to look at how can we get them additional assistance on top of that wound vac so they can actually use it. A lot of times if I'm going to send a patient home and tell them they have to change their dressing every day, usually in a good wound care setting, you'll send them home with at least a week's worth of dressings. Why do you think we would want to send them home with a week's worth of dressings? Won't do it otherwise, good. And here's the other thing, we procrastinate. So if I tell you you have to go out and get these dressings, it's gonna take you a little bit longer, maybe a delay from case management as well, Alex. That's a really good point, right? It may take case management a couple of days in order to get them the appropriate home care and the appropriate home resources, right? The other thing is, we are a traditional lazy society. So if I send you home and say, I need you to go to the, down to Walgreens, I need you to get, 4 packs of 4x4s, I need you to get medical tape, I need you to get Vasodilation, and a couple other things. If I don't give you a week's worth of supply, you're not going to get it in time that you need it. So you need to make sure that these patients have the appropriate stuff to take care of their wound. Now that may cause some of their hospital costs to go up, right? But at least they're going home with the appropriate supplies they need. And that's really important to these patients, because if we don't take care of them, they're going to be right back. In this country here, if you come in and you're a patient that's coming in for a wound, the one study I showed, about 40% of everyone that comes into the hospital with the wound returns within 4 weeks with complications from that wound. Up to 40%. That's ridiculous, right? So that means they didn't take care of it, or they had some complication that goes along with that, right? In other countries, they actually incentivize doctors and case management and therapists and everything, that if you have repetitive clients coming back for the same wound, you may not get reimbursed at the same rate. Because we want to provide initial quality care so they don't have to keep coming back to us. So it's just important that we know that. So we're going to look at the wound sizes, right? We're going to look at the characteristics, wound's location, wound size. We're going to look at tracings, photography, volumetric measurements. We'll talk about TBSA in a little bit when we get to burns. I think we're going to cover burns tomorrow. But let me get a drawing down here. Let's see how well I can draw today. Probably not very well. Okay, so I've got a wound. Here's my wound, right? And we're going to say, that way is my head, that way is my feet. When we're documenting on that wound, there's a couple things we have to get. And we're going to document the wound like we have over here on the clock scale, okay? So whenever you're measuring length and width, the important thing you have to know is that length and width have to be perpendicular to each other. Now that doesn't mean you have to go right across at the middle of the wound for your width. You want to go across the wound at the widest portion of the wound, right? But they do have to be perpendicular. That's the important thing to understand. So when I'm measuring this wound, I want to measure, I'm going to change the colors here real quick, hold on. Go to purple. When I'm measuring this wound, I have to measure from its highest point down to its lowest point in a straight line, right? So that would be my length. And then I'm going to have to come along here and find out where, I'm going to say right about there is my widest point. And again, in a straight line, I'm going to get my 9:3 measurement. Now, you don't have to document in your notes. 12:6 measurement is 13 centimeters. 9:3 measurement is 15 centimeters. I don't know, right? What you will document is length is 12 centimeters, and everyone understands that length of a wound is going to be on the vertical axis, right? So typically going from cephalad to caudal, and it's going to be the longest portion of the wound, right? In a straight line. Does that make sense? Now, I don't want to measure, and I see some clinicians that try to measure like this at an angle. And I clear that one, undo that one, undo. Or you're not undo it, whatever. Change colors again so you can see. You don't want to measure at an angle, okay? You want to measure straight up and down, right? So it's going to go from here as far down as you can go to the other end, but it's got to be a perfectly straight line going 12:6. And then anywhere along, you'll get your 9:3 measurement. What else would we have to get for the wounds? So we've got our longest and our widest portion. Tongue-tied today. Or not just today. Depth, good, right? So we're gonna clear this. They're all drawings, right? So I didn't want to undo. So, you know, we need to get our depth. So then we're gonna have to come somewhere along here, right? So we've got our length, we've got our width. Somewhere along that, we have to get how deep it goes. Now, when you're doing that, maybe, let me get my drawing back here. Maybe the deepest portion is right here. That's okay. You don't always have to document where the deepest portion of the wound is. That's the important part. You're gonna put max depth, though, is 2 centimeters. Max depth is 5 centimeters. And in most wound care measurements, I've yet to see one that doesn't. We do measure in metric systems. We don't measure in inches. That's because that's the way the billing units are based, right? We're also gonna have to look, we're gonna talk about tunneling and undermining next. But we may have to look and indicate if there's any tunneling or undermining. We also have to indicate if there's any rolling of the skin. But the main measurements you have to get on your wound care are your length, your width, and your depth. Those are 3 things you must have on every wound that you treat. Because if you don't get your length and your width, you can't get your number of units you're billing for that patient, right? But let's say I'm going in to see a patient, you know, I'm going to go in and see, you know, let's just say I'm going in to see Alex, and Alex has a wound on his calf, right? So I'm taking his length and his width measurements and stuff like that. If I don't get them accurately, I'm not going to be able to bill him properly, right? Because I need to measure that and bill that based upon the square area that I had, right? So square area is also, you know, looking at the length times the width, and that's going to give me my units. It's not unheard of in the hospital to have 120 units for one patient. That's crazy, right? It sounds just insane. You're like, wow, they spent that much time with the patient. Well, they may have only spent 15 minutes with the patient. But the actual wound billing is based off surface area. And there are going to be some changes to that coming up, I think, with Medicare. Medicare is looking at just going to flat fees for wounds, and they're going to do similar to the PT eval, where they grade the level of the wound. But that's coming up in the future. All right, let's clear my pretty drawings here. If nothing else, this class shows you that I can't draw. I think you already realized that. So here's some pretty wounds, right? As you can see, they've got length and width. So a lot of times you just have to specify where the foot is, where the head is, right? And then get your length and width based on it. Annotate. This one here is not very well drawn, but you need to make sure that if you're gonna do your length, it's a straight line, not that funky curved line that they did there, right? So you gotta get that from 12 to 6 and make it nice and even. I'm losing my voice. Oh, that was just, so let's say we have a wound like that. That's, I was getting there, actually. It looks like pants. Let's say I've got a wound that looks exactly like this wound down here, right? So it looks like it's a pants, right? When I'm measuring this wound here, I have to measure it, even though I've got kind of 2 tunnels that come off, I've got to measure based on that whole thing. So my length is going to be based upon my apex to my vertex as far as I can go. Right? That was really bad. Undo that one. So I got to get it from here and go all the way down to the base of that wound. It's really hard to draw with the mouse. That's a little off, right? Where's my width going to be for this wound? What do you think? Yeah, the bottom of the tunnels, exactly. Because we could come up here and say that's the width, but that's not accurate, right? So our width is really going to be from here probably to here, right? That's going to be our widest portion of the wound because we have this wound down here, and that makes that wound a little bit more outlandish in its measurement size. But as it heals, it's going to show improvement. And that's the important part with wound care. Wound care, the one thing that we always want to be seeing is improvement. Because if we don't see improvement with the wound, what do you think is insurance going to do? Excuse me. They're going to start denying treatment. What they're going to say is, you are not improving the wound, so we are not going to pay for it. And if they're not going to pay for the wound, Ouch. That's going to affect things because then the hospital may have to eat the wound. And you don't want to do that. Let's clear my drawings. It does look like pants sent out. I see it. I have no idea what all these drawings are on here. Just go with it right now. So tunneling and undermining. This is we brought up before. What is tunneling? I don't remember what I wrote all over these last time I taught this class. That's the problem. What is tunneling? Yeah, part of the one that goes deep, right? So tunneling and undermining are often confused with each other. Because if you look at the official definition of tunneling and undermining, they're very similar. What tunneling would be is, let's make this really thick. Tunneling would be an area of the wound that forms and goes to another area, right? My first patient that I had was a patient with a scrotal wound. They had gotten this was my very first patient. I said that when I asked who knows how to do wounds, yeah, this was me. He had gotten an infected pimple on his scrotum. He had anesthesia of the area due to diabetes and didn't take care of it. He had lost all of his scrotum. It was a pimple, yeah. So it had affected him so much that, you know, the scrotum, everything was gone. He had no scrotum there. Not only had done that, but had eaten away almost all of his lower stomach. And there was tunneling going all the way up in almost 8 inches into his stomach itself. That was just sad. Sorry, I got a text message real quick I had to respond to. So when you have tunneling, it's where a wound itself is going to a different area. Undermining. Undermining, let me get the different drawing here. Undermining is where if you can, under an edge, if that edge retreats back a little bit further, so if this edge actually goes back deeper under here, that would be considered undermining, right? So if there's a pocket, yes. If there's a mine under the edges, that's undermining, right? Whereas tunneling typically goes off to another area. Now, in your traditional wound care, if you actually get CWS and everything like that, certified wound care specialist, a tunnel is a hole that leads to another wound. So CWS classifies undermining tunneling as the same thing because if this tunnel here doesn't go anywhere, it just is there, it's technically undermining, right? Fistula, yeah, fistula would definitely be going to another area. Fistula would be going to an area that there's an opening. So let's say that patient that had the scrotal wound, the fact that that fascia underneath all of his stomach area was gone, there was a fistula there leading up into his abdomen, right? So when we document tunneling, let's say, let me clear these pictures here. We're gonna do some fresh drawing here. So let's say I've got a tunnel that goes like this, okay? And I've already got on here head and foot. If I have a tunnel that goes off like this, what I'm going to use is my clock measurement and get a different color. My clock measurement to determine where it goes. So if you were putting that, if you had to so here's 12 o'clock, right? There's 12 o'clock. What would you call that tunnel? Yeah, so 1 to 2 would be good. I probably just label that as tunneling at 2 o'clock, right? And then the measurement, the depth that goes in, right? So don't say 2 p.m., tunneling at 2 o'clock. That's the way they typically, and sometimes we'll say tunneling at 1400, just because that way we don't have to put the o'clock as well. But yeah, so that's tunneling at 2 o'clock, and then your depth of the tunnel, right? So max depth tunnel, 8 centimeters, right? With undermining, in this case, this is, so the black stuff here that's in this black drawing here is all undermining. Does that make sense? So with undermining, you're going to indicate where the undermining starts and where the undermining ends. So what would you say with that undermining? How would you classify that undermining maybe? 10 to 2? Okay, yeah, I could see that. I may even say 8 to 2. So I'm drawing my straight lines here. Let's draw my straight lines. Boom, boom. That starts a little bit below 9 o'clock. Do you see that? So I may even say, you know, 9 to 1:30. Yeah, you don't have to put the 30s. But usually I would say, yeah, 9 to 2, 10 to 2, somewhere in that range. The idea is to see if it improves. And then once you have that, you have to find out, let me clear this stuff off again, where your deepest part of your undermining is, right? So once you get that deepest part of your undermining, then you're gonna indicate deepest at 1 o'clock for 3 centimeters, right? So we're gonna talk about typing out a wound note here in a few seconds. The next thing you have to indicate is, what does the wound look like? How much of it is granulation? Granulation is nice, red, pinky tissue. What makes up granulation? So we had that question earlier. Nope, usually not. Well, I mean, if you're down deep enough, most of the nerve endings are gone anyway, but you can say they're still gonna feel you digging around down there. So you gotta be gentle. Ouch, yes. What makes up granulation tissue? We had that question earlier. What's the primary consistency of granulation tissue? What's it made up of? Collagen, exactly, right? Excuse me. So your type 1, type 2 collagens and stuff like that that kind of lay that ground, the matrix, right? So you have collagen. You have elastin. What do you think elastin's job is to do? Gee, I wonder. Any idea what elastin's job would be? How about to return elasticity? Yes, pliability, right? It's ability for it to shape and change again, right? So elastin is going to come down. It's going to lay a grid work down, right? So collagen is going to come in, and the fibrin and the fibrinogen are going to lay down a mesh work where that collagen can come in and fill in. So that's what, so you have collagen, you have fibrin, you have fibrinogen, you have some elastin coming in that area. All that makes up that granulation tissue. The good news is we don't have to indicate how much of it is fibrin, how much is it is collagen. We just have to call it granulation tissue. Granulation tissue is healing tissue. And it's usually that red, beefy type tissue, right? In this case, it's all this nice pink stuff in here, right? That's our granulation tissue. The next thing we're gonna have to indicate is if there's any slough, right? So slough is the yellowy, pussy type stuff that's in the wound. What ideally are we gonna wanna do with the slough? Remove it. Yeah, we need to get it out, because that's all dead white blood cells for the most part, and infection, right? So the job of that is to get all of that out. So how can we get some of that stuff out? What do you think? How can we get slough out? Good, mechanically debride, good. Scrape debridement, good. Can you use TheraHoney? Absolutely, actually TheraHoney is really great. Spray it out, right? We're gonna get in there and we're gonna clean it out. That's what I'm gonna do when we do the virtual lab, is we're gonna dress a wound and kind of talk about how to dress the wound. When you get that slough out, the sooner we get that out and get just good red, beefy, pink tissue, the better that wound is gonna heal, right? Sharps maybe, exactly. And then the other tissue we can have is eschar, right? Or black dead tissue. That is necrotic tissue. So I'm looking at this wound here, and I don't think that's eschar there, but I think that's just a hole. But if that was eschar, I had to indicate it. So when you're gonna do the note, you're gonna indicate what percentage of the tissue is granulation, what percentage is slough, and what percentage is eschar. How much should that add up to? 100%, yay, yes. I love it when I see somebody that indicates that there's 50% granulation tissue, 60% slough, and 20% eschar. Wait, what? Right? you need to be able to add up to 100, right? So it needs to be even. We're also going to indicate also what's going on with the wound edges, right? Are they indurated? Are they folded over? That's when that skin kind of rolls underneath, right? And if that skin rolls underneath, it's not going to approximate well. In that case, we may have to get a PT, because what's the PT maybe have to do if that skin is indurated? Cut it, yeah, right? They're going to have to come in. You know, if we're looking at this, and this whole area here is maybe indurated. Well, that was a really bad drawing. This whole area here is indurated. They're going to have to come in with sharps and remove all of this to get it back to where there is no induration. Now, the sad part is that means they're cutting into skin, right? And guess what's probably still there in that skin? Yeah, pain. There's going to still have nerve endings, right? So that's not going to be the comfortable part. Usually taking wound care measurements, they might, oh, that's kind of uncomfortable. But they're not complaining. But if we have to go in and cut off fresh skin, that's not going to feel good. And unfortunately, a lot of times as PTs, they don't have the ability to order some sort of a numbing agent. Maybe the doc will be nice and will give us some numbing agent for that area, but a lot of times they don't. So you're cutting and trimming on that skin, and they just have to kind of suffer through it. I think it's a little bit cruel, but if we don't cut that indurated skin off, it's not going to heal right. And they're going to actually heal by secondary intention. And we don't want that. So we've got to clean up that skin. Right? We're also going to look at the drainage. Right? About how much wound drainage do we have? What if, you know, we've got a lot of slough in there, we've got a lot of fluid, right? We have to indicate that. Usually when we talk about drainage, remember when we talked about getting up fluids from the lungs, we talked about minimal, moderate, right? And what was the other term we used? Minimal, moderate. My favorite word in the whole wide world. Severe could be. Starts with a C. Copious, yeah, right? I don't know why we don't do minimal, moderate, maximal drainage, but for some reason, it's minimal, moderate, and copious drainage. Right? Copious means there's a lot of drainage in the area. So we have to indicate that. This is what you're going to do when you first go in. You want to look at the wound and go, what does this wound look like? You know, you want to have how much drainage is there. What color of the skin, right? If we still have red, like we have up here on this edge of the skin, what does that mean that area of skin's still under? Inflammation, right? That skin is still inflamed. So we got to make sure that if we're on that we can indicate how much inflammation's in the area. And then also, let's say that I got this wound around my nail bed and the nail is gone. Well, we're looking to see if I'm getting new nail growth. If I'm not, it's called denuded, right? That means that there's no skin, there's no hair or nails growing back in that area. Maybe you have a wound on your head. And sometimes if you get a wound on the head, the hair follicles won't grow back in that area. That would be an area of denudation where there's nothing growing back that should be there. We also have to indicate if there's any edema, temperature, and if they have sensation in that area. How are you going to know if they have sensation in the area? Oh, yes, smell for infection as well. Oh, yes. You're going to have to waft that drainage, see if we get any smell from it, right? So how are we going to know if they have sensation in that area? Well, we're going to test it, right? We're going to kind of probe along that wound edge, right? We're going to take and kind of come along here and feel along this whole area and make sure they've got kind of normal functioning sensation. The good news is, as we're cleaning that wound, you usually can tell if they're getting sensation back because they're going to be going, hey, that doesn't feel good, right? So you're getting some sensation as you're going through anyway. So let's look at this wound here. So we've got a wound. Excuse me, I don't know why my voice is going. We've got a wound here. So we've got indicated, there's the head, that means down here is the feet. Let's classify this wound together. So we're going to measure from north to south. And let's say that that north to south is 12 centimeters. Oh, wow. Let's not do that. Let's undo that. That was a really bad drawing. Let's do text. So length equals 12 centimeters. And let's say width is about most of it, so 8 centimeters. Oh my God. All right, so we've got our length and our width. What else do we have to document on this one? Depth, okay? So let's say we got depth. Well, after we measure depth equals, say, 2 centimeters. So now we got our depth. Good. So let's look at our percentages on this wound here. So the key thing you have to look at here, first of all, is this stuff here, the yellow stuff, is that slough or is that skin? What do you think? Yeah, it's probably skin and a little bit of sub-Q fat, right? So that we're not going, okay, so we got to be careful with that, right? We don't want to say that. Where do we have slough at about? Where can you see slough on this picture? Yeah, bottom right, right? So down here. So you have some slough down here. Do we have some good granulation tissue going on? Yeah, right? All this nice red beefy tissue in here is good granulation tissue. Do we have any eschar? That's a trick question. Yeah, it is, right? We got some eschar right up here. Now, as a PTA, we really can't do much about that. So we're just going to have to leave it and maybe document it, let the PT know we've got eschar. What else do we have in this one? What else do you see? Yeah, we have a tunnel, right? We got a tunnel down here. We don't know how far it goes. And I'm looking at this and I know because I took this picture, but on this wound, along here, we have some indurated skin and we have an undermine, right? So we've got some undermining going on. I just know this because this is off our wound model and I took this picture. So we have to get all of that. Yeah, that's actually not a bad percentage. Good. That adds up to 100%, Alex. That's good. So let's go ahead and we're gonna clear all this and we're gonna kind of document this wound. Right. So I'm gonna go down here and let's change the text to, let's do green. The green everyone should be able to see. Right. So we're gonna have to document this whole thing. So we're gonna have to document our length, our width, our depth. Right, so we got that. So we're going to go with Alex's measurements here. So we're going to say 75%. What are we going to call that? Can everyone see me typing? Just want to make sure of that. Granulation. Everyone can see that. Okay, good. Right, so Alex is 75%. So we have about 20% eschar, and we have 5% slough. So we're going to go with his measurements because that's actually a pretty good estimate. So we've got that. We got to put that in there. So now we're going to have to document. We have a tunnel. Where's that tunnel at? Where would you say that tunnel's at about? Okay, good. So tunnel at about 1700. Okay, somebody say 4. So we'll argue, but I say it's 5 too, but we'll just go with what I said because I'm right. No, just kidding. You don't have to go into the 30s. Just kind of estimate about where it is between them. I'm going to say 5 o'clock, and we have to have what on that tunnel? Depth. So let's say it goes 3 centimeters deep. We've got our tunnel. We also have an undermine. Where would you indicate the undermining at about if I told you it's over there on that side? 6 to 9. Okay. Yep, that works. So 1800 to 2100. And then in this, we have to have a max depth, and we'll say that it's 2 centimeters. So we've got that. We've got the measurement. We've got our tunneling. We've got our undermining. We got our tissues. Is there anything else we need to indicate? That's my preference. It's just because that's where I worked at. We had to do it in military time because that was what it required. Because there was this weird thing in the, good, we have to indicate sensation. And a weird thing in the system, if you documented it with regular time, it kind of translated it weird when you typed it in. So I just have a habit of typing military time, so you don't have to. Sensation, right? So sensation, intact, oh, hit the caps lock, normal at wound edges. Good. Drainage. Minimal, odor. So what does that, if I put that drainage, minimal, no odor, and colorless, what does that probably tell you about the fluid? What kind of fluid is that considered? It's pretty healthy, right? Yeah, it's usually just serous fluid, or it's just going to be edema, right? So anything else we have to indicate on this? So we got our eschar, we got our wound depth, we got our wound width, we got our length, got our drainage, we got our breakup. So overall, that looks pretty good, right? It looks like it's healing, right? So that would all go where on our note? Oh, good, yes, because these are all active measurements. Now, I'm going to use that O to compare it to what? I'll answer that question in a second, Shazette. Oh yeah, with the date of injury, we could. That's going to be in the documentation. So Alex, that's a really good question. But the date of injury is going to be in the actual chart for that. So we don't really have to indicate the date of injury on it. Unless it's a new injury. In that case, it's the PT is going to document the date of injury, right? But Alex, look, the other Alex is right. We're going to indicate, compare this to the previous. And when we compare it to the previous, where does that go in our note? Hey, good, in the assessment portion. Right? So we want to indicate how does it look? And we don't have to, we wouldn't say, again, just like we talked about with, I'm drawing a blank here. My brain is not working. Oh, like pain. We're not going to indicate in A that pain is down by 2 points, right? But if we notice that the length has decreased, we can put length of wound decreased from previous session. That's okay. That's not saying what's causing that stuff. It just says it is, right? That's allowable. Where we would get out of our scope of practice is if we would say length of wound decreased due to enzymatic debridement treatment last session. Now we're starting to step into that where we're making a true assessment of what improved it, or making an evaluation on the wound itself. And that is just a PT responsibility. We're just going to indicate if it's bigger, smaller, whatever it is, right? We're not going to say length of wound increased due to patient's lack of compliance with wound treatment. Nope. We may put if patient is compliant or non-compliant with wound treatment, but we're not going to indicate that that's what's increasing the size or decreasing the size of the wound. All that goes back to PT responsibility. We don't want to step on their toes, right? We want them to make all of those hardcore assessments and all of those hardcore evaluations and reevaluations of the wound, right? Now, because we have to indicate how far along the wound is, again, I mean, we're not going to hard dive. It's not, we're not going to say wound has progressed to partial thickness wound. You theoretically could in the assessment. Well, we really don't too much. I may indicate in my assessment, wound appears to be healing normally if it looks like everything's kind of closing off. Or I may put wound is not healing effectively. And then on my plan, I'm going to put speak to PT about wound healing, right? If we notice that this wound has eschar and didn't have eschar before, what might we want to do? So before you came in, there was no eschar, and now we've got 20% eschar. Yeah, we may want to call a PT, right? This would be one, especially if I haven't had it before, that I'm probably going to tell the PT right off the bat. And the good news is most of the time that we're doing wound care, the wound care therapist, the hardcore PT, is usually going to be available by phone. So I may call them and say, hey, John's got eschar on his wound today. Do you want me to, is there anything you want me to do about it? Or do you want to come check it out later? Right? Because eschar means dead tissue. And we know that dead tissue likes to do what? Spread, right? So we want to get that taken care of as soon as possible. A lot of times if you tell the PT they've got eschar, they're going to say, hey, I'll be down in about 5 minutes. Leave the wound open. I'll dress it. Because they're going to come down and cut it right out. right? So just be aware of that, that we have to let the PT know if there's something like that where they've got dead tissue. We let them know that there's dead tissue there now. It's kind of important. Now, don't freak out, right? Don't be like, oh my God, they've got 1% eschar. Oh my God, PT, code blue, we've got eschar. You don't have to go that far, right? But you do want to let them know that there is eschar growing on that wound, because that we want to get rid of. If it looks the same, maybe slightly better, would you say it looks improving? That's a really good question, Alex. I'm trying to think of what I would do in that case. I may put that wound is progressing as per plan of care. That would be a good way of saying that it's slightly better, but I'm not, I'm not seeing much improvement, if that makes sense. I may not indicate anything. I try to keep my notes as simple as possible for wound care. But yeah, you do want to have something, an assessment that shows that it's improving slightly, or that it's getting worse. Because if it gets worse, yep, I'll explain soft in a second, Mike, no problem. If it gets worse, we want to indicate that, because getting worse, we've got to determine what's causing it to get worse, right? So say this time we went in and it's 12 centimeters. Last time it was 4 centimeters, right? That's gotten worse. And we have to get the PT to document why it's getting worse, because if we just put that it's increased in length, right? Insurance is looking at it that we increased the length of the wound, right? Whereas maybe it's increased in length because the patient was picking at it, which happens a lot. That's why we want to cover the wounds so the patients can't pick at their wounds. Because if you have one of those scab pickers, they're going to constantly be picking at that wound. And we don't want to always allow that, right? So we want to make sure it's covered up. Yeah, that would probably be a good idea. I mean, it's a lot of the, especially if you work in a hardcore wound care clinic, a lot of times if the wound is getting worse, the PT's got to do a re-eval. And the good news about the re-eval with wounds is it only takes a few seconds. It's not like they have to run through a ton of, special tests and stuff like that with them. They can walk in and look at your measurements and kind of get an idea of what's causing that. And they'll put an addendum on your note. It'll say something like, PTA indicated wound has improved or increased in length. Looked at wound has increased in length because patient is non-compliant with dressings, right? I've had a patient once that as soon as I put the dressing on, they had a sacral pressure injury. As soon as I put the dressing on and walked out of the room, they peeled the dressing off. And it was frustrating because you couldn't keep that dressing on. And so eventually we had to go with the the way we kept the tape wound on is we went with the McConnell taping, or the brown tape. And they couldn't pick at that brown tape and pull the dressing off. Now we didn't put that brown tape on the wound. We got an extra large dressing and then used the tape around it so that they stayed away from it. Coband's kind of that stuff's easy. That stuff they put around your arm when they do like blood draws and that. But the McConnell tape, or I'm trying to think what the name of the Leukotape, there it is. That Leukotape is a really sticky brown tape. And if you use that, a lot of times it won't come off. So we had to do that with the patient. Okay, so slough real quick. Back to Mike's question. What did I say slough is? It's not sloth. It's not like, hey, you guys. Yeah, maybe it's some dead tissue, right? A lot of times slough is made up of, it's yellowish, good. It can be kind of mucousy too. What is slough primarily composed of? Not necessarily dead tissue, but it does have some dead tissue in it. White blood cells, yeah, right? White blood cells, exactly, right? So if you have a pimple on your face, technically that goop that's in your pimple is slough, technically. I mean, yeah, so pus, yeah, a lot of times we don't indicate pus. We're going to call it slough just because it sounds better. Pus typically indicates what? Because pus has a smell typically. So pus typically indicates infection, right? So if the slough is smelly and kind of white and gunky, yeah, that's technically more pus than it is slough. But we're just going to label it as slough and indicate what it looked like, what the drainage looked like, right? But yeah, if we have true pus, we've got an infection, right? So slough, I always think of slough as what's in a pimple. It's just kind of the dead white blood cells. What primarily type of white blood cells do you think it is? What do you think the primarily slough is made up of white blood cell wise? Could be T's. Yeah. I was just going to say it's primarily your phagocytes, right? What are your phagocytes' jobs? If you go back to Michael Crichton's book, the phagocytes' job is eaters of the dead, right? Yeah. They're the cleanup tissue. They come in and clean up. And so once they've done their job, they die. And that's kind of what slough is. Slough is those dead cells that have just kind of eaten their way up. The good news is they're still contained in their little cellular membrane. And so once you wipe them out, they're out, right? If they pop and they kind of spread in that area, now you can start developing eschar. Because now you got that dead tissue kind of starting to spread through the whole area. And it's just like anything else, that dead tissue likes to spread. Does that make sense? Does everyone understand kind of how to do wound characteristics? And, oops, I wanted drawing. Go away, undo. Oh, redo. So does this all kind of make sense here? Oh, we forgot one other thing. What else we do need one other thing in that wound characteristic. We have to indicate where the wound is. Temp, you could, yeah. The green text will be in the lecture, the audio. Well, it won't be in this, it won't be in the lecture that's on there, but it'll be in the audio lecture for you. I can put it on the other lecture for you. It's okay, we can go back to undermining. Temperature we could indicate, yeah. You should probably, you know, normal temperature is normal if it's hypothermic or hyperthermic. And really think about it, it's probably one of the areas I neglect now that I think about my wound care, so I've got to improve that. I actually don't often indicate what the temperature is in the wound, and that's actually probably better that I should. We also have to indicate just where it's at, right? Is a sacral pressure injury? Is it a sacral wound? Is it on the calcaneus? If it's on the calcaneus, which calcaneus is it on? Because we want to indicate that so the next person coming in to follow you up for wound care, you know, comes in and goes, hi, you know, I'm Keith, I'm from PT and I'm going to help you with your wound today. Let's go ahead and redress it. That way I can go exactly where the wound is. And I'm actually going to put up a sample soap note for this as well so that you guys can kind of see it. But does that overall make sense for you guys? And then undermining. So what is undermining again? Again, if I'm going to talk about it. So let's say I have a wound here that looks like this, right? What would be undermining? See if anyone can define it okay. So let's say this is the edge of my wound bed, right? If the stuff underneath here has retreated back, this is why tunneling and undermining can be confusing discussions. Some of that skin, let's say that it's retreated back that far. That skin can then flap down. That means there's an undermine there. There's a mine under noted pocket around the edge, right? Exactly. Now, again, in traditional wound care, we call that all an undermining, even if it goes back deeper. If it goes to another area, we call that a tunnel. But if you're looking for your boards, a tunnel is just a long hole going from that to another area, whereas undermine, yeah, we're going to talk about indurated in a second. So undermining means there's space underneath where the skin is, okay? Indurated, now the skin has kind of rolled under. So there's my thumb. My thumb rolls under. That would be indurated skin. Does that make sense? So here I have space underneath it, undermining. Now I have indurated skin, and I actually still could have an undermine under there, right? And that would be where this PT would have to come in and cut all this indurated skin off in order to allow it to heal. Does that make sense? I know this is a kind of complex topic. Are we okay? No, it doesn't have to have induration. Okay, thank you, Melissa. That makes sense. And that's why it's hard in the pictures, and that's why when I do the actual kind of the wound care models, it'll help you make sense. So that's why I'm gonna try to, so we have a wound that looks like this, right? So this part of my hand here is the wound edge, okay? If I have a gap underneath this wound edge, right? You have the gap underneath that wound edge, what is that considered? Undermining, good. That would be undermining. Now, let's say now my skin is folded under, and I still have undermining here, so I still have a gap, but now my skin is folded over like that. What is that called? Indurated, good, right? So if I had something like this, I would have to indicate that from 12 to 2, maybe this range, I have undermining with a depth of however many ever centimeters at the deepest point with indurated edges. Does that make sense? Does that help clear it up a little bit? There's not a picture. As I said, when I do the actual, so what I'm going to do is I'm going to video the wound care model, and we're going to kind of walk through it. That'll help make a little more sense. I have some videos that I'm going to post up of different wounds that'll help you understand it a little better as well. But I just want to make sure you guys get the basic sense of it. So tunnel is a long cylindrical, typically, opening that goes to a different area. Undermining is a gap under where there's healthy skin. Indurated is where that healthy skin kind of folds under. And that's not going to then approximate. Yeah, that's actually a really good point. So out here on my shirt where I have that fold over, technically that fold would be indurated. Yeah. How long for an undermining area to become a tunnel? Okay, hold on that one. So yeah, great example. So like with this shirt here, in order to remove the induration, you'd have to take a pair of scissors and cut that fold off, right? Now, just because I have my shirt out like this, because there's gap underneath the shirt, that would be undermining under the shirt. Now, if I can go from here and go all the way out the other hole of my shirt, I'd have a tunnel. Does that make sense? So how long is the undermining area to make a tunnel? Most of the time, most of us that do wound care only consider it a tunnel if it's kind of cylindrical and it goes somewhere else. It's better to indicate it initially as undermining, just because it looks better. But if we know that it's going, so if we can take, I don't have a pen here. Darn it. Should have had, oh yeah, hold on. I think my iPad pencil here. Right? So if I can take that probe and I can go in and it goes pretty deep and I don't have an area to kind of make a half moon or something like that. Right? If I can go in and it's just there and I've got no space, I usually call that a tunnel. If I can go in and I can make kind of half moon out of it or make some space or even a quarter moon, that's more typical for undermining. Does that help clear it up? And again, when you see the wounds that I'm going to show, so in this picture here, right, let me grab my annotation here. This is more of a traditional tunnel, right? And if we stuck a probe, if we took my iPad pencil and shoved it down there, I don't know why I shoved my iPad pencil into a tunnel, but it would go down that way. We're going to use probes, not like pens and pencils. Over here, you've kind of got a space under this whole area of dead skin over here. Right? Not dead skin, but skin. And that goes back, it's almost probably about that far in this wound care model. So that would be more classic undermining. Are we surviving? We're at about, I want to try to get to about slide 40 today. That's my plan. So look at that, we've got those measurements, we did that, we did wound drainage. So when we're talking about wound bed preparation, we're at 37, we're almost there. Okay, we're almost done. We're almost done. I'm gonna let you guys go and then you can start working on your quiz and stuff like that and do your follow-up here. So we're talking about wound bed preparation, right? We wanna look at the tissue. Is the tissue healthy? Is there a lot of granulation? What's going on? Where am I? You're at home, Mike. That's where you've been for a couple days. Is there inflammation or infection present? Is there moisture management? What if, a couple weeks. What if the wound is dry? What do you think we're going to want to do? Yeah, we're going to want to hydrate. We're going to add moisture, lotion. Well, we don't necessarily want to put lotion in a wound, but we're going to add moisture to it, right? If the wound is too moist, because you can be too moist, I just love that term. Right? If you're too moist, we want to take some of that moisture away, and that's going to come into our dressing types. And then what do the edges look like? And I'm out. So this is looking at the tissue, assessment of the debridement of non-viable foreign material, including necrotic tissue, any dressing material that got stuck, any foreign organisms, biofilm, slough, anything like that. We want to get anything that is not healthy, beefy granulation tissue out of there. A lot of times, especially if you're using the 4x4 gauze pads, those 4x4 gauze pads, I'm going to mute after one more time. Those 4x4 gauze pads, I don't know if you've ever used them, right? So 4x4 gauze pads, they tend to leave little trailers, little strings off of them. You got to get that out, right? You don't want to leave any of that behind. I've seen a surgeon close a wound with the sponge still in it. If you have that tissue in there, and that stuff in there, it's not going to heal. So you got to get all that gunk out, the slough, the exudate, all that, anything that's in there. If there's any type of infection, we got to get that out. If we want to get necrotic tissue, any eschar, we got to get it out. If we don't get it out, that wound is not going to heal. So we've got to make that nice, beefy, and red. Assessment of the etiology of each wound. We need to know if we need antiseptics, right? Can we order a topical antiseptic as PTAs? What do you think? Let's say we're looking at a wound and we're like, oh man, it looks like it's got a little bit of infection. Let me just go get some Vasodilation and put it on it. You think you'd want to do that? You'd only want to do that if the PT has evaluated and said that we can use it. So if there's already a note in the eval saying Vasodilation use as needed or PRN for wound care infection, then we can. If there's nothing there, we can't use any type of a chemical. We can't even use meta-honey unless it's in the eval to be used. Does that make sense? So anything we're adding to the wound to help it heal has to be in the documentation for the wound, right? But let's say we think that the wound could use some antiseptic. I'm not going to put in my plan, talk to PT about antiseptic use, because that seems like we're trying to do what to the PT? Yeah, we're kind of stepping their toes. We're trying to tell them what we think should be done, right? And I've worked with PTs where I'm the primary wound care person, and the PT is literally just coming in and doing an evaluation and knows almost nothing about wounds, right? They're just going in and doing the evaluation and passing it off to me to take care of, right? I may think to myself, or I may, and this can be a problem too, I may think to myself that I know what's better for that patient, but I still don't want to step on those toes. I want to make sure that I'm diplomatic about it, right? I may talk to PT about current infection state of wound. That's okay, but I'm not going to say, talk to PT and have PT, evaluate for antiseptic use. No, that's kind of stepping on their toes, and we don't want to do that. We kind of want to give them the autonomy to be the real doctors of this, and that's the important part. Management of inappropriate inflammation, unregulated infection. Maybe they've got systemic inflammation going on. We may have to treat that as well. Do PTs always have to indicate super specific instructions? So PTs don't have to indicate specific instructions on what type of dressings to use unless those dressings are impregnated, right? Maybe they've got a silverdine impregnation or something to that effect, or we're using copper dressings. They have to indicate if we're using a special dressing, but they don't have to indicate that we have to use 2x2s instead of 4x4s, or they don't have to indicate that we have to use cloth tape instead of elastic tape. But when it comes to anything that we're adding to the wound, they do have to be specific. So if we're adding something like meta-honey, they have to be specific on that. If we're going to do pulse lavage to remove some of that, and we're going to talk about pulse lavage later, it's basically super soaker with suction. They have to be very specific about us doing pulse lavage. We can't just do pulse lavage. But they could say, treat wound with least restrictive dressing possible, and that's fine. Then it's on us to pick the dressings. But again, if we want to take that step out and use, maybe we're looking, oh, you know what, this patient could really deal with an AG impregnated, which is silver, an AG impregnated dressing, they have to be specific about that. And in that case, I may say, talk to PT about current state of infection, and then the PT is going to go in and document, add silver impregnated dressings per PT order, and then we're fine. Oh, I'm not going to say we got that bad word imbalance here. Right? If we have that bad word imbalance, we have to figure out how to fix it. If they're too moist, we've got to take some of that moist away. If they're not moist enough, we've got to add some moisture to it, right? And there are different dressings we can do with that, and there's different things we can add to increase the moisture or decrease the moisture, which we'll talk about when we actually do a dressing. And we have to kind of assess what's going on with the wound edges. What do the wound edges look like, right? Can you guys see on this wound here? Let me get my little annotation up. Can you guys see how this edge over here is kind of indurated just by looking at it? It kind of rolls, right? So that part there would have induration. It's probably also got some undermine. Yep, great, good, yes, 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 you're getting the idea of it. So we probably got some induration, we've got some undermining. It looks like the whole wound edge is indurated. Do you see that? I mean, there's maybe, where's my drawing at again? Maybe down here on this edge might not be indurated as much, but the rest of that wound looks like it's indurated. So that means that PT's got to come in there, and guess what they got to do to that whole wound edge? Cut it away. Because if they don't, with that being rolled under like it is, these wound edges won't approximate. So they won't come together. So instead of coming that way, it's going to fill up with non-healthy tissue. And that's going to be that healing by secondary intention. All right, so how are we feeling? Are we fried? Okay. So I'm going to close out my screen share here and bring me back to here. All right, it's been a while. I know that's why I have a couple days planned for wound care. Relax. So let's talk. What have we learned today? You've learned that you're brain dead? Oh wait, that came before that. We learned characteristics of wounds, right? Good. So let's talk about documenting. Good. Let's talk about wounds. What are our three primary types of wounds? What are our three primary types of wounds? Based upon superficial, good. What's the next one? Partial thickness and then full thickness. Great, right? Superficial involves what layer? Epi, right? Partial thickness goes down into the dermis, and then full thickness, we're going through the dermis and down into the sub-Q area, right? Good. So if I had a cut on my arm and you could see biceps, what would you call that? Full thickness. Good, right? That's the idea. Great. I'm glad you guys got that part of it, right? And then with documentation, we have to document our length, width, depth, right? Document if there's any type of percentage of tissues, right? So we got to be very specific on that. The more specific we can be, the better we can document that this patient needs therapy. Okay, so we've got to be very, very, very specific, or at least as specific as we can get. Then again, specific without stepping into the ranges of evaluating, right? So we want to be very, very specific when we're doing stuff like that. We learned the stages of healing, right? We have our inflammation, we have our proliferation, we have our remodeling maturation phases, which you've talked about before in patho, and we talked about before in modalities, and we've talked about before in PTA208, way back when we started with Intro to PT, right? We've learned that, when doing the measurements, it may not feel very comfortable for the patient, but it's not going to be as uncomfortable as you guys think, because a lot of times those nerve endings are kind of cut off. So they don't have them all, right? When you're going down that tunnel, a lot of times the nerve endings are gone. So you're getting an accurate tunnel measurement. And I'm going to show you how we're actually going to physically do a wound. We're going to measure. We're actually going to take and document on that wound, and we're actually going to dress and undress the wound and dress the wound, right? That makes sense, so that you guys can see kind of the process. Because we still have to go over the types of dressings, and that's a lot more to go with. Right? I'm telling you, I actually didn't like wound care to start with, but once I got into it, I found that it's kind of a nice break, because it's not so much worried about getting this patient up and getting them moving, so much as getting that wound to get better. And a lot of times, if you are doing wound care, that is all you're doing. It's not like I'm going to go in and do wound care and then get the patient up and move as well. I'm coming in for wound care. Somebody else is going to come in and do actual PT. Does that make sense? So a lot of times it's not that way. Now, let's say I have a total knee replacement, and that dressing is just completely saturated and that dressing needs change. Well, in that case, I may do some wound care, but I'm still there to see them primarily for PT. A lot of times I've had a patient where I've gotten them up and moving. Maybe they've been down for a day or two with total knee replacement. I get them up and moving. That dressing just gets saturated, because now all that exudate and all that, the serous fluid that's in that wound is now getting sucked up into that dressing because they haven't moved enough. And then we get them back to the room, and I've got to remove that dressing and change the dressing. It's not always nice to go to the nurse. Hey, I got the patient up, I got them moving, dressing looks horrible, go ahead and change it for us, right? But you have to also then be specific about your hospitals, because certain hospitals will not allow you to change dressings. So you have to know what your hospital's guidelines are. We'll actually start it off, believe it or not, started off more PT and less nursing, and then nursing has kind of taken some of it from us. And nursing actually is completely and utterly happy to give it back to us. I'm going to be dead honest. If you tell the nurse and your hospital allows you to change dressings, you're like, hey, the dressing in 202 needs changed. Is it okay if I do it? She's going to be like, kosher, go do it. I love you. Because that's one less thing she has to worry about, especially right now. Up at, what's that festival that's up at the Speedway every year that's annoying, kids with the really annoying music. Thank you, EDC, there we go. At EDC, there's a tent up there that's medical tent. And a lot of times I've gone up and volunteered up there to do just minor dressings and stuff. I'm not evaluating them. All I'm doing is, oh my God, they fell, landed on their butt, and they've got a cut, and I've got to dress it. So a lot of times PTs and PTAs may volunteer to do stuff like that, where we're just doing basic wound dressing. We're not evaluating it. We are not being, we're not treating them medically. We're just kind of get them and send them on their way. Now, they come into the med tent. Yeah, this is med tripping. You come into the med tent and suddenly they've got a pole going through their chest. We're probably not going to do wound care on that and send them to the hospital. But, minor cuts and scrapes, a lot of times it's fun to do that kind of stuff. And that's what a lot of the PTs right now are doing in the emergency care department, is like New York specifically right now has PTs handling most of the musculoskeletal cases and most of the wound care cases that come into the hospital. Because that way they can free up the docs and the nurses to handle the sick people. Because we can't put people on vents. Put a Band-Aid and get back out there. You got it. Yeah, please. Anyway, are there any questions about this lecture today? Okay, good. We're doing okay? Okay. So what's going to happen today? Again, I'm going to post up. You've got to do your little survey about this lecture. The quiz is going to go up today. It's not only about today, but it's going to go up today. So that probably won't be due, not next week, but the week after, because there's going to be stuff from the next couple lectures in it. Okay? Because the quiz is the kind of a comprehensive wound care quiz. So you can open it and start it if you want, and then kind of go back to it. In your the schedule, I put the chapters where a lot of this stuff comes from and indicated what books I take a lot of the sources from. But you'll notice that I borrowed stuff from a lot of our book library. So I may have taken some stuff from PR, from physical rehab, and I've taken some stuff from Therex. I've taken some stuff from your original modalities book and stuff like that. So it's not all out of one book. There's not a new book for this semester either, other than the study guide for your test. So the one thing you will have to do after today, so you have to do it within 24 hours, is the kind of, what did you learn from this lecture? What did you like? What did you not like about this lecture? That has to be done within 24 hours for me. We're going to have one of those every day that we lecture. And then, like I said, there'll be a quiz for each of these kind of subtopics. So there'll be a quiz for this. There'll be a quiz for ergonomics. There'll be a quiz for vestibular, PNF review, all that type of stuff. Are we good? Any specific questions I can answer? No, I'm gonna have to email her, text her. I didn't get a text back, so she might be busy. I know they had a lot of meetings, making sure that we've got all the preparation in effect. Obviously, because we're in a kind of toward situation here with having everyone to have to do at home. I'll get her. She'll probably show up tomorrow then when we talk. Because you also have her tomorrow at 2:30, I think, after me. So tomorrow you'll have me to start with at 1 o'clock, and then at 2:30 it'll be 2:04, so the administrative procedures with Dr. O'Neill. I don't know if she's going to have you do a lecture online. You have this class tomorrow and Wednesday. So let me bring up the schedule real quick just so that you can see it. Maybe I thought you guys had gotten it, but let me bring it up real quick here. Give me 1 second here. Or share screen at again. There it is. So this is your schedule for the next couple weeks. So you have special topics, right? So you have special topics Monday, Tuesday, and Wednesday. And then you have admin procedures just Tuesday and Thursday. So you have me 3 days a week and an admin 2 days a week. Does that help make sense out of it? And I'm pretty sure Tuesdays could be long. Don't forget, they may not all be, and not all my classes are going to be where you guys have to be on here. No, you're going to do it in this room here because it's the only room we can have multiple people in. I think. She'll let you know. I'll let you know by tomorrow too. So not all my lectures that we're going to do are going to be where we have to be face-to-face. There's going to be some video lectures as well that I'll put up for you guys as well. So maybe you don't have to necessarily be in at 1 o'clock exactly for it. You can do the lecture at some point in the day. Okay, but we're gonna make sure that all the lectures go up so that you guys are covered. Yes, absolutely. Yeah, what I'll do is so if I tomorrow was going to be a video lecture, I would tell you today that tomorrow your lecture is going to be posted. Please review your lecture and do the quiz associated with that lecture. Like I said, you should be on this channel here. She should just step over and take over from me, and I'll make her the host. Folders are good. I haven't activated the survey folder yet. It's not up yet. So if you try to do that already, it's not showing right now. There'll be a folder that says class surveys as soon as I make it visible to you. I just don't have it visible yet for you. Same thing with the quizzes. The folder's not the quizzes aren't showing. Any other questions I can answer for you guys? All right. So that will be it for today. Tomorrow we'll finish off most of this lecture that we've got to cover. And then, like I said, my plan is for Wednesday to start doing the wound dressing and stuff like that. I'm going to go into school. I'm going to break out the different types of dressing so we can I can show them to you and we can go over and you'll see what they look like. It was Carl Baskin. Is there a Carl Baskin in this room or what? I have no idea what you're talking about with Carol Baskin. Maybe I just missed out on that. Oh, okay. Yeah, that's not going to happen. All right. So I'll post up the survey for you guys. I have to watch a Netflix documentary. I'll post up the survey for you guys. The quiz will go up right now. And you guys are good to go for the day. Thank you for your rapt attention. I can't stop watching. It's fantastic. And like I said, as soon as I get this compressed in video format, I'll post it up to YouTube and post a link. Thank you guys. Have a good rest of your day. Thank you, Dr. Sokel, for showing up.